I would like to welcome you that you come to our home, okay, Sheba Medical Center, Tel HaShomer. I don't know, it's open? Low battery, what means? It's okay, can you hear me?
Yes.
Okay, so I welcome you to come to our home, Sheba Medical Center. Just one comment that I would like to have the next time in Paris. Okay, revenge. 1 year here, once in Paris.
Okay, we will tell.
And Salomon, he know where to do it, right? Laurent? The last time we meet? No. Okay. Okay, so I would like and thank the organizing committee to invite me to this lecture. My topic will be Anomalies of the Aortic Arch, Correlation between Fetal Ultrasound, Postnatal MRI and CT, Correlation between Fetal Ultrasound, Postnatal MRI, CT, and this is a lecture combined with our pediatric cardiologist that he will lecture following my lecture. So anomalies of the aortic arch, particularly the double aortic arch and right aortic arch, may form vascular ring by which aortic arch by which aortic arch and its branches completely encircle the trachea and the esophagus, thus causing clinical symptoms of compression. Most of the data regarding these anomalies have been reported in the pediatric and radiologist literature using computed tomography, CT, or magnetic resonance. So the first aim of my presentation is to describe the in utero ultrasonographic findings between fetuses with right aortic arch, double aortic arch, using the cutting edge of technology. As you can see here, this is the high definition, this is the inversion mode, and this is the new high definition, and we have a super new one, which is the silhouette. Which is a silhouette form of high definition, and to compare it with CT or MRI postnatally. And the second aim is to explore possible tracheal compression in utero and to compare it also with postnatal imaging studies. Three types of aortic arch are existed. The normal left aortic arch, and the definition of left or right aortic arch is according the arch that crosses the bronchus. In the normal left aortic arch, as you can see here, the arch crossing the left bronchus over the left bronchus, while right aortic arch, as you can see here, the arch is crossing the right bronchus. Double aortic arch, there are two arches that are encircled by, the trachea is encircled by both arches. The basic knowledge of the arches is already published by our group in 2002. It's what we call the three-vessel tracheal view together with Simcha. And just to show you, it's a transverse sections of the heart just above the four-chamber view. We go up. This is in your fourth or second? The second, okay. Okay, and if we look on it from left to right, you can see this is the main pulmonary artery with the ductus arteriosus. This is the left arch. This is the superior vena cava. And this is the trachea in the middle. So both of the arches are on the left side. This is the normal view. The incidence of right aortic arch is about 0.1 in the population. We can have a right aortic arch with right ductus, and we can have right aortic arch with left ductus. The right aortic arch with right ductus usually is not a problem because there is no ring or complete or loose ring above the trachea and the esophagus. We have a high risk for Tetralogy of Fallot if we have right aortic arch with left ductus arteriosus, a more microdeletion of 22 de Georgi, and the outcome is of this consequence is partial or loose vascular ring around the trachea and the esophagus. Double aortic arch, we can see we have double aortic arch with left ductus as with right ductus, and in both cases the two arches are forming complete vascular ring with tracheal compression with neonatal stridor with early need to surgery. And you can see that the clinical feature of these neonates, the symptoms are when both arches are widely patterned, there is tied ring and stridor in the first week of life, and if there is, some of them can be atretic, so the symptoms are later because there is no full ring, and rarely double aortic arch is present in adulthood, as you can see here. These types of left aortic arch, how it is by ultrasound, this is what we call the V sign, the normal left aortic arch, the V sign. The right aortic arch, we call it U sign. And the double aortic arch, as you can see here, we described it as N sign, and you heard it before, how to get the images of it. So we analyzed our data from 2005 to 2017. We had 46 cases of isolated abnormal fetal aortic arch. We removed all the complicated cases with cardiac malformation. We have 32 cases with right aortic arch, what we call U sign, and double aortic arch, we have 8 cases, 38 with right aortic arch, 8 cases with double aortic arch. Postnatal imaging, in the 38 cases, because they are not so symptomatic, we have only 8 cases, and all the cases with double aortic arch, we have postnatal imaging. Just to show you that the diagnosis can be made very early from the 13 weeks of gestation in the early anomaly scan. Of course, this is abdominally, the right slide here, the U sign, and this is the normal V sign, it's 13 weeks and 5 days, so it's very easy to see it in the first trimester. You can see the abnormal right aortic arch, the U sign, both the ductus arteriosus and the aorta are in parallel position. When we look on our cases, we notice that we have 2 cases from the 38 cases with mirror image. That means that all the vessels, there is a normal configuration of the neck vessel, and 36 cases we have right aortic arch with aberrant left subclavian artery. As you can see the difference between the mirror image and the left superior aberrant left subclavian artery, you can see that we have 4 vessels here, and here we have the normal configuration of 3 vessels. They nominate, and this is the carotid and the subclavian here, and in this case you have a aberrant subclavian that is emerging behind the esophagus, as you can see here, and it's emerging from what's called the Kumarel diverticulum. This is Kumarel, it was a German physician, and he described it for the first time by X-ray, that this is the Kumarel diverticulum. This is the place where the left subclavian artery, the aberrant one, is emerging. And you can see here, this is the left superior artery, left subclavian artery with the Kumarel here from backside, from behind. This is the Kumarel diverticulum. You can see the Kumarel diverticulum by power Doppler, and you can see it by high definition here. And this is by angiography and 3D reconstruction of right aortic arch from behind. And we want to compare it to 3D reconstruction of right aortic arch by transvaginal at 13 weeks. As you can see here, this is 13 weeks. I will zoom it, and you can see very clearly the aberrant left subclavian artery, the right aortic arch, and the Coumarel diverticulum. So right aortic arch with ALSA can be confirmed, as you can see here, by the postnatal study. You can see the left subclavian artery. You can see it here, left subclavian artery, aberrant left subclavian artery. What about double aortic arch? In the double aortic arch, we notice the true vascular ring that can be two types. One type is when the arches are of unequal size, as you can see here, and we have 7 cases that the arches are equal size. Both the left arch and the right arch were equal size. And you can see this is the ultrasound. You can see in the type 1, the left arch, which is here, is much smaller than the right one. You can see it here. And when we compare it to the postnatal, what's happened there, left arch was obliterated, and there is a spontaneous obliteration of the left arch. And the radiologists come to us to say, the pediatric cardiologists come to say us, no, there was no double aortic arch, because they didn't recognize it, because it was it was spontaneously obliterated. This is a cartoon to showing you that there is a double aortic arch with atretic segments. The type 3, the second type, when both limbs are equal size, you can see here and here, left aortic arch and right aortic arch, and this what form the true vascular ring. As you can see here with the postnatal imaging. What about our second aims? Our second aims was to explore tracheal compression in utero and to compare it with postnatal imaging studies. As I said, the manifestations of the neonates with arches, with true ring, is mainly a compression of the trachea manifested by the early stridor, and we wanted to identify those cases who will need emergent surgery after delivery or not. And we ask ourselves if it is possible to predict tracheal compression in utero. You can see the normal trachea, what we call in all 3D, 4D. You can see this is the anterior view of the X-ray model of the 3D. You can see here this is a trachea, and here are the bronchus. And in the sagittal plane, you can see this is the trachea in black. Trachea is in black in utero because it's full with fluid, with the amniotic fluid. With the new 3D, 4D, you can see the vascular ring, and you can see the trachea inside. This is the silhouette that enables us to look for it. So in our 46 cases, we look on the trachea, how it's appeared in utero. And we notice that we have 35 cases, there is no compression on the trachea. We have 9 cases, there was a mild compression of the trachea. And we have even 2 cases of severe compression on the trachea. Among the non-compression, all of them were of right aortic arch. So right aortic arch or non-compression appeared in all cases of right aortic arch, while mild compression, 1 case of right aortic arch and 1 case of double aortic arch, and 2 cases of right aortic arch and 7 cases of double aortic arch. So most of the cases with double aortic arch have some sort of compression of trachea, while most of the right aortic arch, almost all of them, has no compression of the trachea in utero. Severe compression we noticed in 2 cases. In 1 case with right aortic arch, and in 1 case with double aortic arch, and I will show you. This is the 35 cases out of 46 cases with no compressed trachea, manifested only in right aortic arch. This is a coronal view. We took a volume, and then we work on the volume. we navigate on the volume until we get the real trachea. You can see the trachea in black, the two bronchi, the ductus arteriosus, and the right aortic arch. As you know, this is the parallel view, the U sign, because they go, if they are normally, they go on one side. And again, in the clip, you can see very clearly the trachea is open and there is no compression on the trachea. Mild compression of the trachea appeared in one case with right aortic arch. I hope you can see here the diameter. There is a large diameter, and here it's almost half of it. This is approaching the carina, and you can see the narrow. Okay, this is a mild compression of the trachea compared to non-compressed trachea in right aortic arch. As you can see here is the 3 millimeter, and the diameter is 1.2 millimeter. And in order to make the images better, we can do a reconstruction by inversion mode. As you can see by inversion mode, that there is some compression of the trachea in this case. So the inversion mode make you a cast forming. It convert the black to the white, and by this you can have the images of the trachea like in a cast. So mild compression of the trachea was in 7 out of 8 cases. You can see here again the mild compression in double aortic arch. Okay, double aortic arch, that means you have here right aortic arch, the left aortic arch, the main pulmonary artery with the ductus, and here is the trachea, which is compressed here. Again, mild compression of the trachea in cases with double aortic arch. You can see here. This is the prenatal, and this is the postnatal imaging to show you the mild compression of the trachea postnatally. And since all these cases, most of them were from the double aortic arch group, before surgery, we perform a bronchoscopy, and you can see what we call the fish mouth appearance. Okay, here you can see the compressed bronchus here before surgery. Severe compression, as I said, we have in 2 cases. One of them was on 16 weeks, as you can see here, 16 weeks. You can see that the ring is very tight here. And this is the multiplanar of this case. Okay, this is the sagittal, this is the coronal, this is the transverse, and this is the render of it. And you can notice that here the trachea is enlarged below the ring. The trachea is enlarged. And we got a echogenic enlarged lung because the trachea is occluded. And the differential diagnosis for the enlarged trachea is what we call congenital high airway obstruction. When we have a laryngeal atresia, as you can see here, the larynx is occluded here and the trachea is opened and is enlarged. Okay, so in congenital high airways obstruction, you have the lungs that are enlarged because there is no access to the fluid in the heart, in the lung. This is laryngeal atresia. And this is the clause that is congenital low airways obstruction that is due to the vascular ring. Here all the trachea is enlarged, and here only the part of the trachea that is below the ring that is enlarged. The second case of severe compression of the trachea in utero was before delivery. We noticed in 37 weeks of gestation that this is the trachea. The patient was followed up during all the gestation. There is no polyhydramnion. Few days before delivery, we made a fetal heart rate recording, and there was a fetal bradycardia. Usually for us, the normal heart rate is between 140 to 160, and here the heartbeat was below 120. It was between 100 and 100 beats per minute, so it means that there is some vagal compression on the trachea of the ring. Okay, this is the vagus, so and you can see it here again, the very narrow trachea, and it is immediately after delivery. The neonate, the baby, we could not respirate in the delivery room, so it was we inserted the tube, and this is the CT taken. As you can see, the trachea is almost occluded here. And this is the images of the postnatal. You can see here the reconstruction of the trachea, and I'm sure Ishai will show you better images of the reconstruction with the very compressed trachea. Finally, this neonate died after a prolonged hospitalization in the intensive care units after surgery. Another variant of tracheal compression that it was not included in this group, but it's very interesting to show it. It is what we can see here. This is the Tetralogy of Fallot with absent pulmonary valve. When we have an absence of pulmonary valve, as you can see here by the Doppler, the pulmonic artery, the giant MPA, main pulmonary artery, is crossing the trachea and is pressing on the trachea. And I will show you how it looks. You can see here, this is the main pulmonary artery, this is the trachea, this is the prenatal. You can see it here on the 2D, that you can see a stop in the trachea that goes behind the large main pulmonary artery. This is from the prenatal, and this is the postnatal, and the images are quite similar. Again, another case that we have of right aortic arch with tetralogy of Fallot with absence pulmonary valve. When we have a tracheal compression, severe tracheal compression, you can see it here by the inversion mode. This is the normal trachea with bronchus, and here you can see a very narrow case. So, in summary, we have the in utero evaluation of the vascular ring. We have non-compressed trachea. There is a mild compression of the trachea, and even severe compressed trachea can be diagnosed in utero. We have our fetal cardiovascular clinic that is a multidisciplinary team involving the obstetrician, genetician, pediatric cardiologist, pediatric cardiosurgery, pediatric pulmonology, pediatric radiologist, and neonatologist. All of them work very near to us, so there is a very, very good collaboration with them. We call them to the ultrasound unit. We make a common discussion about the patient and so on to give them the prognosis. Even patients are coming from far away, so they have the one shop in Sheba Hospital. This is the advantage of a big hospital like Sheba that can give all this counseling in one spot. Just to show you the natural history, during the collection of the cases, this is a case from 2010. You can see here the aberrant left subclavian artery. So usually you call the patient and you ask them, how is the baby, right? You want to know the follow-up, okay? So I called the patient, how is the baby? She said to me, 7 years ago. She's 7 years old. She told me, no, the baby is okay, fine, no problem. Then 1 month later, she came to me to scan in another pregnancy, and she told me, listen, I told you that my baby is okay, but he has some problem of swallowing and some problem in the respiration. So I told her, what have you done? She said, okay, I went to my pediatrician. What he said? That he has some allergy. Okay, and what he said, okay, take some medication. And is it helped him? No. So what you have done, he sent me to a neurologist. I said them, no. You have time immediately to do MRI. So the symptoms arrived only 7 years old, and this is the MRI that Ishai performed, okay? And you can see the 7 years later, the aberrant subclavian artery with right aortic arch. So in conclusion, among 38 fetuses with right aortic arch, 8 were evaluated postnatally. In all, ALSA was noted. However, only 3 were symptomatic. The other 5, the mother were symptomatic. So they worried about the consequence, so we performed them the MRI, even they were not so symptomatic. Our right aortic arch may cause tracheal occlusion in utero, what is Klaus. Among 8 cases with double aortic arch, all the diagnosis was confirmed. One spontaneous atresia of left arch was verified. We have 1 neonatal death due to severe tracheomalacia in the case that I showed you. High-resolution ultrasound enabled accurate prenatal diagnosis and tracheal assessment. It is possible in utero. Double aortic arch may be symptomatic in utero and cause severe tracheal compression at birth. And of course, postnatal MRI or CT are need to confirm the diagnosis before final intervention to assess compression of the trachea. I would like to thank you for the attention. This is the staff of the Sheba ultrasound only unit here. They are working when I'm lecturing here, so they are good staff. I would like to acknowledge to all our team that work on this project. Professor Efrati from the pediatric pulmonology, Dr. Hegesh, Dr. Salem from the pediatric cardiology units. Jeff Jacobson is here from the pediatric radiology. Mishali and Professor Saref, you know him, from the cardiac surgery, and Masquet from neonatology unit. Thank you.